Welcome to the Providers Report, where we delve into the world of value-based healthcare. Our mission is to empower healthcare providers with the knowledge and tools they need to deliver exceptional patient care. Each episode, we explore best practices, innovative strategies, and real-world examples of how to achieve the highest standards in patient communication and outcomes. Join us as we transform the future of healthcare, one conversation at a time.
Hey guys, welcome to Better Doctor Project, where we interview healthcare providers to tap into their experiences so we can turn our challenges into our biggest strengths. We hope today's episode inspires you to take that next step to become who you want to be in practice. I'm Dr. Beck.
And I'm Dr. Mack.
Let's get started. Hey, it's Dr. Beck. Welcome to episode 8 of Better Doctor Project. This episode is a little bit of a spinoff from our usual material, so kind of like a special episode. We decided to touch base with Dr. Jim Eubanks, a physiatry resident from the University of Pittsburgh Medical Center, about his experience with the start of COVID-19 back in March and April, and how it's really been changing healthcare more and more every month since. Keep in mind, though, this was recorded mid-June 2020, so just a couple of months into the heat of the global pandemic. Currently, it's mid-August 2020 when this episode's being released, and sadly, things haven't improved all that much. So let's hope for some great change soon. Whether we want it to or not, this pandemic affects so many factors in all of our lives. For literally everybody, especially us as healthcare providers, though. How has it affected you? I know in my office, we're doing so many things differently from a protocol standpoint, so clinically, there's obviously been some changes. There's also been a lot of change from an emotional and social perspective with my patients, too. Is there a certain way we in healthcare should be responding to this? Are there opportunities we're missing out on where we could actually be helping others more? Check out what Dr. Jim Eubanks thinks in today's episode all about COVID-19. The best part? There's zero politics in today's episode. Absolutely none. So when you're done, don't forget to also check out episode 4 with Dr. Eubanks, where we talk all about healthcare teams and why they're so important. Thanks, guys, and have a great day. Hello, everyone. We are back again today with Dr. Jim Eubanks. Thanks so much for joining us.
I'm glad to be here again. Thank you so much.
Of course. So today is very different from the last episode that we had with you. We're going to be talking about basically what not to talk to patients about, the don'ts, as I like to call them. So religion, politics, the current hot topic of COVID-19. So personally, in your field of healthcare, in physiatry, has COVID-19 affected you as a healthcare provider, and how did it affect you?
Yes, so that's a really great and broad question. It certainly has affected all of us to different degrees. So I was attending the Association of Academic Physiatrists annual assembly in March of this past year, when things were really starting to come to full acknowledgement in terms of the seriousness of COVID. And we were really the last set of conferences that took place before most medical conferences at that point said, we're gonna cancel because of COVID. And so by the time we were in Orlando, unfortunately, the AAP had no attendees develop COVID within the 2-week time frame after leaving, which was excellent. We're very happy about that, particularly because it was an international joint conference this year, with the International Society of Rehabilitation and Physical Medicine. And so we came back to Pittsburgh and realized that COVID is a problem that needs to be specifically addressed. And so one thing my program did is, while it is trying to gather information from institutions like the University of Washington that were early hit, right, out in Seattle, we were also transitioning our program to where we actually became all inpatient, and we postponed our outpatient services. All of the residents were working inpatient, and what we did to stagger potential exposure and reduce it in the event that there were exposures, because at that time it was a mandatory 2-week quarantine. So if you were exposed to someone who developed positivity or was known to be positive, then you were kind of out for 2 weeks, right? And that really takes a big hit on a program if you're losing physicians. So some programs would lose like their entire team, in a single day, because one patient on the ward would be positive.
Wow.
And this was all before we had reliable ways of ascertaining information about whether someone was going to be positive or not, right? So you just had to do a wait and see kind of thing. So we had half of our residents working inpatient, essentially, and then half of them were on a remote support service. So it was really great for us, because those who were inpatient, we would have support through a remote system from our other residents that were assigned to our team. So I know particularly early on, I was actually in the hospital. It was me and another resident and 2 attendings for our particular service. And then we had 2 to 3 residents from home, essentially signing into the EHR system to help us do things like chart review, to prep notes, to, if we had admissions, they would help with orders, and they would be able to do a lot to offload the burden on us to sort of prevent burnout, but also, again, to be available in the event that one of us ended up being exposed. So that was an early thing that started really in March. And other things that changed that were notable included going to a virtual didactics or lecture series. So in residency, there's 1 day a week where we spend pretty much half the day in lectures and learning different topics. So all of that was transitioned to a remote system. And that's something that I think we're going to see probably stick around, is the expansion of remote learning. And the other thing, of course, is telemedicine. So telemedicine, there was a rapid transition across the board to utilize telemedicine and become more familiar with its capabilities. So one of the things that we've seen here in Pittsburgh is it has great utility with follow-up appointments that are mostly about checking to make sure that a patient is progressing as expected, right? So it can be, telemedicine can be used to screen people, to say, it comes back to the ultimate question in medicine, which is sick or not sick, right? Like that as an intern, that's your entire job, is to learn how to tell sick from not sick. And in medicine, that at the most rudimentary level, that's what we're trying to ascertain, is what level of intervention is going to be necessary for this person. So you can tell a little bit of that from telemedicine. And in fact, interestingly, in Pittsburgh, we coupled our 911 system with opportunities to interact directly with physicians through telemedicine. So if someone called in 911 during, the COVID lockdown, they could, based on the level of seriousness of their problem, have a telemedicine session with a physician on the other end.
Wow.
That was kind of rolled out specifically because of COVID. So we're taking a lot of like technology that exists but wasn't habit.
Mm-hmm.
We're implementing it out of necessity, because new solutions were necessary to address this novel problem. I think we're going to see that, and we have, that a lot of people who were hesitant about telemedicine are now welcoming it. And we still have, pretty much, to my knowledge, all of our attendings are using telemedicine as part of their daily schedules in ways that, wasn't the norm before. So I think we're going to see that certainly continue to stay and grow. And that's a good thing. It was a catalyst for that technology.
Yeah. And personally, my favorite part about telemedicine is that it opens the door for patients completely outside of the norm, who just don't feel comfortable leaving their home, possibly. Maybe they don't feel comfortable engaging with healthcare providers in a clinical setting due to fear of that, or who knows what else. And I feel like this provides them access to healthcare without having to cross those bridges.
Couldn't agree more. And it's interesting because the fact is that if you look globally at access to smartphones, smart devices,
Mm-hmm.
and this is quite staggering, but a true fact, and that is that more people now have access to smart technologies than toilets. Yeah. So this is a moment where we have a tool that is quite ubiquitous and already available to us, that we can connect patients to the healthcare system in some ways that they did not really have reliable access to before. So I think it's a net positive here. We're going to see a lot of increased access because of this.
I know one of the things that you're passionate about is mobile health and integrating that into healthcare a little bit more. Can you tell us a little bit about what you're working on?
Sure. So I want to give a brief shout out to Dr. Brad DiCiano, who engineered a really wonderful program called I'm Here. And it's a smart application for smart devices like iPhones and smartphones and tablets that is specific to rehab. And what it tries to accomplish is bridging the gap that we have between that in-person clinical visit and when the patient goes home and spends, the majority of their time, right? So if we want to change health behavior, we can't just rely on a clinician telling them in the clinic, what they should or shouldn't be doing. That's not enough. And no wonder it fails time, right? So it takes an average of one in-person clinical session to educate a patient about smoking cessation. You have to do that 50 times to have one person actually change their smoking behaviors, right? With exercise, it's actually a lot better. It's about 1 in 12. But that's still, we need something else to help augment that. And the potential for mobile health to bridge that gap is there. And so one of the things that we're doing here in Pittsburgh specifically is using technology that, again, is already available to all of the patients that we have, and trying to use it in favorable ways and positive ways that are going to help enhance positive health behavior change. And so these are systems that are designed to capture information during the day that are important to both the patient, such as their eating patterns, their medication use, if they have certain disabilities, their supplies that they need for disabilities. And it's also capturing other types of medical system use. So you can track how many times they need to go to an urgent care center or an emergency department, for example.
Wow.
And these systems are secured in such a way that they can communicate back to a designated clinician. So that's one of the incredible benefits of this technology. Similarly, something I'm involved with is through a research track that I'm doing is looking at prehabilitation for patients undergoing lumbar spinal stenosis surgery. One of the things that we have changed about that program, specifically because of the changes due to COVID, is we have 3 prehabilitation visits essentially for patients that are going to be enrolling in this program. The first one will be an inpatient or an in-person assessment. So not inpatient, but rather outpatient, but in person. And that will be the first session. And then after that, however, the second and third session will be using telemedicine. We're trying to unburden them a little bit with technologies that we know that most of these patients have, and we're trying to utilize that more. So.
Yeah, absolutely. So obviously for providers, we've noticed all of these big changes, some of which are definitely going to be around for the long haul. But obviously our patients have been affected too, and some positive ways, but definitely a lot of negative ways. We're seeing a lot of mental health issues come about or worsen with everything going on with COVID-19. So I feel like because of all this change, they're coming in possibly differently than they would have pre-COVID. Have you noticed in your field any patients bringing up COVID to you, wanting to have that discussion with you? And when they do, how are you handling that?
That's a great question. So we did have patients who would be taken care of on the inpatient side. And, then it's time for discharge. And they've been watching the news in their rooms. And several times they would have panic, pure panic about leaving. And is it safe? So you can imagine that if you're a transplant patient, which we take care of in our medically complex unit, a lot of transplant patients who are already immunocompromised and being told, you have to watch out for infection, they're watching the news and they're hearing all about COVID-19, and they're naturally and appropriately concerned about their risks. So we have to do a lot of educating, particularly because, the reality is that their risk of acquiring an infection is greater remaining in the hospital than going back to their own homes and following the observations and the recommendations that are in place to socially distance and wear masks and sort of limit their exposures. So most of the time we have to sit down with patients and kind of educate them on what the status is on the recommendations that they should follow. And I think that most of the concerns that patients in particular have are very legitimate. And we have to remember that they're asking from a place of genuine concern. And the first step is to give them good information. So that's a responsibility that we have as clinicians, is to be up to date enough about what the status is on those recommendations that we can reliably give that to patients who ask.
That's a great point. What about the opposite end of the spectrum? Maybe a patient where, you're discharging them, you're going to give them some information on how to handle things outside of the hospital, and they either could care less, they possibly mock the situation, make a comment about how they'll never wear a mask, or how it's, the famous word is a hoax, if you will. So what's a good way to handle those kinds of patients yet remain professional at the same time?
So it's important to realize that I think the majority of people will recognize good information coming from a person who is in a position to speak intelligently on that. And the most people will take you seriously when you spend time explaining it to them. Mm-hmm. So I think in those cases where you have someone who's resistant or hesitant, if you actually spend a little extra time saying, hey, this is my job as a profession. It's my responsibility to know what's good information, what's bad information. And I'm telling you, this is the good information and here's some of the reasons why. That's the first step, because most people you're going to win over, actually, because they're going to take you more seriously as their personal clinician than, some random person they hear about on TV. It's also really important to recognize that people are going to ultimately do whatever it is they do when they leave, right? So you can't take the burden on of controlling their actions. You're not going to do that. That's not part of what you do. What you can do is give them good advice, good information, and try to have them invested in your advice enough that they take it seriously. And some of that is a craft. Some of that is skill that you develop as a clinician over time. But I think that by and large, it's more surprising to see patients come around to appreciate what you're saying than not.
Well, and the vast majority of patients truly are going to give you what you allow. So if you're a provider and you're making light of the situation, even if it's indirectly, they're going to pick up on that. And that might help feed that conversation. They might think they can get away with saying something that's either inappropriate or controversial because they feel like you might be open to it. So I feel like you're right on the money. If we truly stick to what we know and what our job is as healthcare providers, if we present them good information, stand our ground, show that we care, and give them what we can give them, even if they disagree, I think the most that they can do is just take it for what it's worth and walk out and do what they're going to do anyways. Yeah.
And document that you had the discussion.
Always. I know you mentioned earlier too, it's important, it's our responsibility to have the right information to the best of our ability. Right now, social media is pretty popular and a lot of people are turning to that for their information. And I'm wondering what your view is a little on how providers should interact with social media when it comes to Facebook, Instagram, et cetera, with this kind of information when you do know that you have maybe the most up-to-date, to your knowledge, information. You want to be able to share that with people. Should you be bringing it onto social media? How should a provider react in that situation?
Great question. So I do think it's our responsibility as people in positions to speak on this topic to do so. So if capable healthcare professionals are not talking openly about the good information available up to this date, because it is evolving, and that's part of science working, right? If we don't speak about these things, then it's going to be the loudest person online who wins. And so fortunately, there's been a good movement throughout the past several months with this pandemic for persons in positions of expertise to speak more openly about what the public should and shouldn't be doing, where they should get information, and how they should think through changes that occur naturally as we acquire more information about these topics. So that is something that I like to emphasize to patients early and often, is that changing recommendations is a reflection of the system working properly, right? We don't know everything 2 weeks after it starts. 2 months later, we're going to have different ideas about what's best because we've gathered more good information about what to do. And all of that is a signal that we're doing the right thing. Sticking to our guns simply because we said it early on, despite having new or more information, is not a good strategy at all, right? So we have to make sure that point is made to people. And we do need scientists and researchers and clinicians online, particularly social media, challenging bad information, challenging news outlets that, sort of propagate bad information. And that's a part of our responsibility as a community.
I love the concept too, that we're allowing that change and your focus, that's just science working, right? We should never be too high and mighty to question ourselves or what we already know. And I think it also, like Dr. Beck said earlier, sets the tone for the patient, right? That's our job. And so I think it also allows them to have the ability to express that their mind has changed on a certain topic as well when new information comes to light.
Right.
Yeah. So to wrap up this discussion, obviously COVID-19 has been the big topic as of late, but I feel like for decades and decades, possibly forever, there's been plenty of other topics that are not a bad idea to avoid with patients. Do you have any examples of what those might be?
So I think that we want to be socially and culturally knowledgeable and intelligent when it comes to the diversity of our patient populations and what their expectations might be. We need to help them make their expectations known to us. We need to know what their preferences are. They need to know what their concerning problems are, because what we may think, as a clinician is most concerning may not match at all with what they perceive to be most concerning. We've got to try to find that alignment, and that requires conversation. I think too that we have to realize that our role as a clinician is to empower them as patients as much as possible, and that means accepting, their belief systems and their goals within those belief systems. So some of that can mean, that we need to spend more time learning what that is. And some of that may mean that we need to spend more time educating ourselves on what they might be.
Yeah. And as an example, I have one patient that jumps to mind. She's a younger patient, I believe in her early 20s, and she sees me primarily for upper back pain. And every time she comes in and I ask her how she's doing, her response is always something about her energy and her aura and her, current vibe in relation to the state of the universe. You know what I mean? That's what it means to her. And even though it might be something that I don't fully understand, or I cannot relate to or respond with the same terminology that she's using, I let her get it out. I let her talk to me. I let her tell me what she's feeling, how that's feeling. And I've been taking care of her now for over 2 years, and I can get a gist as to where her head is at and how her body's feeling now based on how she talks about that stuff. Even though I still don't fully understand it as a whole, I know that when she tells me certain things in her terminology, I know what it means to me and what I need to look for that day when I treat her. And so that's a great example, of just kind of meeting patients where they are, because you are going to have patients that belong to different backgrounds, and we need to be able to meet them where they're at and understand what that means to them.
Right.
Perfect. Well, honestly, this has been another great episode with you, and we truly thank you for coming on with us and answering these questions for our listeners. I know there's plenty they'll be able to learn, because I don't think COVID-19 is going anywhere for a little bit. So I look forward to all the learning that will come from today's episode, and thank you so much for joining us, Dr. Jim.
Well, thank you both for having me. It was a pleasure.
I'm so excited you could join us for today's episode, because we really wanted to bring you something a little bit different in light of the challenges that we're all facing right now as healthcare providers. Basically, we're pioneers, and right now healthcare is the wild, wild west. So we wanted to make sure to share with you any gold nuggets that we found as we're navigating completely uncharted territory and acting as guides for our patients, friends, family, and sometimes random strangers online. I hope this episode today inspires you to really think ahead this week about how you're going to discuss these issues with your patients when they bring them up, and how you're going to set the tone for what you allow in your treatment space. As you're sharing this new knowledge with your patients, make sure you also share it with your colleagues and let them know they can get all the information on this episode, as well as tangible resources to help them implement these things in practice, whether it's in an office, hospital setting, or any other area where you care for all the amazing people on this planet. Keep your eye out too for tangible resources that'll be coming out soon, not just for this episode, but for all of our other episodes on our website, betterdoctorproject.com. See you in 2 weeks.
We loved connecting with you today on this episode of the Better Doctor Project. We can't wait to share our next podcast with you in just 2 weeks. Same time, same place. Until then, pop over to Instagram to follow us at Better Doctor Project, or keep up with us at betterdoctorproject.com.
Thank you for tuning in to the Provider's Report. We hope you found today's episode valuable and inspiring. To stay updated with our latest episodes, subscribe to our podcast wherever you like to listen. For more resources and continuing education opportunities, visit our website. Together, we can make a difference in the lives of our patients and truly set a standard for value-based healthcare.